Hello and welcome to my YouTube channel. Today we shall be learning about polyhydramnios. Polyhydramnios is a condition where the fluid that surrounds the baby in the fetus in the womb is usually larger than the gestational age, usually more than 3 weeks from the estimated gestational age, usually by dates. You get that the mother gets an abdomen that is greater of the fundal height than the real gestational age. So what are the sum of the causes? There are three main causes. Majority of the causes are related to what we can't really say. You run tests, you get that there is no identifiable cause linking it to this excess fluid. Majority of it is idiopathic, where we really do not know. That is close to 70% of the cases. Some of them are due to maternal causes, where we have conditions like diabetes. So we have to run tests like HbA1c and fundal and fasting blood sugar to rule out diabetes. Rhesus incompatibility, where the mother is usually rhesus negative and the paternal rhesus is positive. So we have some rhesus incompatibility that links this to polyhydramnios. Majority of the causes that can be identified are due to fetal anomalies. And that's why we do run some prenatal fetal anomaly scans. Majority of these causes of polyhydramnios, as mentioned, is due to one increased urination, where the baby has increased production of urine into the system, into the space, causing increased amniotic fluid, or where we have a defective swallowing or absorption of the amniotic fluid. So among the causes that lead to decreased absorption is where we are having some blockage or discontinuity in the gastrointestinal system. This is an example of atresia, where we do not have a complete digestive system. So we may have a discontinuation at the esophagus, lies to be called esophageal atresia. Some may have discontinuation at the duodenum, where we have duodenal atresia. Due to some causes, there are babies who in intrautero still develop stenosis, which is just basically closing up of the digestive system due to some fibers forming or thickening of the digestive system. Some of the other causes are CNS, where we may not have a brain, alias anencephaly. Anencephaly would lead to this because we know that every function of the body, it has a center in the brain. Urination as a function also is controlled by the brain. Swallowing is controlled by the brain. So when we don't have a brain, we are likely in trouble. Other causes like pulmonary, where we are having cystic lungs, where we don't have, when the baby swallows, some of the amniotic fluid goes into the lungs. And when we do not have absorption also in the lungs, may have increased amniotic fluid. Twin-to-twin transfusion syndrome, when the babies are actually sharing a placenta, we usually have one that is the donor and another one that is the recipient. So for the donor usually will usually develop oligohydramnios, where we have reduced blood, and the recipient will have polyhydramnios because majority of the blood is getting into the recipient, and because of anastomosis in the placenta. Actually, when the blood gets there in a vast amounts, the renin-angiotensin system is actually depressed, but it cannot be depressed to a level that is lower than the other. So in the majority of the babies, when this is impaired, we have polyhydramnios. So what do we do? Usually it depends on the age of diagnosis, at which gestation age is the baby, is the mother or the baby rather. We usually do an ultrasound where it is reported that we have an increased amniotic fluid index. Amniotic fluid index is just an addition of the sum of the space that the baby leaves on the sides. I'll demonstrate using my image here on the top left, where we are having, for example, when we add, let's name it A, on this other side, let's name that B. This other side, let's name that C. This other side, let's name that D. So when we add A, when we add B, C, and D, and we get that number is coming to greater than 24 centimeters, then we are likely dealing with polyhydramnios. When the deepest vertical pocket is more than 8 centimeters, the usual is between 2 and 8. We are also likely dealing with polyhydramnios. So what do we do? Depending on the gestation age, we always want to have a plan. The first question we ask ourselves is the mother symptomatic or not? Remember, when we are having increased amniotic fluid, we usually want to check, is the mother having difficulty in breathing? Is the mother having a uterine discomfort? Is this precipitating some signs of labor? If not, we want to see how we can manage that differently from the one who is actually having these symptoms. So we can classify polyhydramnios into, according to severity, where we have mild to moderate and severe. So for mild to moderate, where we're having an FI between 24 and 34, basically, depending on the age of diagnosis. If the mother comes in with these at the age or less than 32, let's say 28 there, or 30 or less than 32, basically, we want to do indomethacin, and according to research, we can do 25 milligrams per orally, up to 4 times in a day. But we don't want to do more than, we want to do that for 48 hours. If we do it more than 48 hours, there is a high risk of closure of ductus arteriosus. So we only want to do indomethacin and betamethasone as also an injection as we prepare. The good thing about indomethacin is that, one, it will reduce production of amniotic fluid volume, and also it will also act as a tocolysis, where it will impair impending labor onset. Remember, these mothers are at a risk of getting a premature labor because of increased pressures in intrautero, and this can really trigger labor to set in because of the release of prostaglandins that can cause cervix to ripen, and also to have an onset of labor spontaneously, regardless of the age. Number two is that when we are having it occurring between the age of 32-34 weeks, we usually don't want to do indomethacin, because at this age, the baby is actually nearing maturity, and indomethacin will lead to closure of ductus arteriosus at this age. So we only do that for less than 32 weeks. So instead, at 32-34 weeks, we want to use nifedipine or terbutaline, and of course a steroid, that is betamethasone or dexamethasone, depending on the facility and the availability at your place. For the scans, we want to do ultrasound. For them that are having mild, that is AFI of 24 to 34, want to do an ultrasound every 2 weeks until the 37th week. When we reach the 37th week, we want to do that weekly. We are aiming at least 39 to 40 weeks, but this is done on a case-to-case basis. If the mother is symptomatic, we may want to just deliver 37 weeks. Number two is that when we are having it as severe, that is more than 24, more than 38, more than 35, that is amniotic fluid index, we want to do it weekly. And of course, if it's symptomatic, we want to do a procedure called amnio reduction or amniocentesis, where we want to get an injection into the amniotic fluid sac and drain some of the fluid. Remember, this is a procedure that is done and we do it so carefully so that we don't drain a lot of fluid, where we may want to land in a risk of getting umbilical cord prolapse or abruption. Some of the complications that we are worried of is that because of the increased intrauterine pressure, we may lead to this may lead to premature labor, or in case and this premature labor can also lead to abruption. We are having abruption where the placenta is detaching from the endometrial wall. We will lead to intrauterine fetal demise. Number 2 is fetal malposition. Remember, when the fluid is in there, the baby will not assume a constant posture. So time to time again, they'll keep on turning, and they might end up with breech or any malposition that is not cephalic, and this might be a complication to consider. Umbilical cord prolapse is because now we are having a lot of fluid. Again, because of the same thing, fluid is around the baby is too much, and this might lead the cord to be as the presenting a part of the baby, and this can lead to fetal compromise. Thank you so much. Subscribe to the YouTube channel, and have a good day.